Welcome back to Diabetic Foot Files, the Royal Wound series, where history becomes a clinical lesson and the body never lies. Today's royal is Alexei, Alexei Romanov, the son of Tsar Nicholas II, whose life and death was shaped by a single genetic condition called hemophilia. This episode is about blood, biology, and balance. I love alliteration because when clotting fails, every wound becomes dangerous. And even when clinicians don't respect the coagulation physiology, even if their intentions are good, it could be fatal. So that's why it's good to ask a real full past medical history. But just a medical disclaimer, this episode is for educational purposes only. Let's make common sense common again. It does not replace individualized medical care. And if you or someone you care for has a bleeding disorder or a wound, especially with diabetes, seek professional evaluation urgently. So, Alexei Romanov was a child who couldn't run freely. He pretty much was the boy who couldn't fall, couldn't play rough, couldn't fall like other boys, and we all know boys are rough. But not because he was weak, it was because his blood couldn't clot. A bump could mean internal bleeding, a bruise could mean days of pain, a small wound can become life-threatening. And that reality didn't shape his health, but it also destabilized his an empire. Today, we're going to unpack how hemophilia actually works, the genetics behind it, why wounds behave differently, how the clotting cascade fails, what types of wounds hemophilic patients are prone to, how we diagnose and treat it today, and how to safely manage wounds and debridement without killing the patient. Okay? So, this is Royal Wounds Hematology Edition Hemophilia. So, Alexei Romanov, he suffered from hemophilia, most certainly hemophilia B, which is inherited through a royal lineage, but it's inherited, okay? His symptoms included spontaneous bleeding episodes, severe bruising, joint bleeding, aka hemoarthrosis, prolonged bleeding after minor trauma, intense pain and immobility. There are no clotting factors, concentrates, no modern diagnostics, and no safe surgical options. Every injury became a gamble. So let's make this clear. Let's talk about the genetics of hemophilia. Hemophilia is an X linked recessive genetic disorder. Here's the keys. Males have one X chromosome. Females have two X chromosomes. If a male inherits the X chromosome with a defective gene, he's affected. If a female inherits one defective gene, she is usually a carrier. This is why hemophilia runs through royal families and why Queen Victoria became known as the grandmother of hemophilia. So, the two types of hemophilia A is a factor 8 deficiency, and hemophilia B is a factor 9 deficiency, which Alexei most likely had no factor, no stable clot. Okay. So, clotting cascade, what goes wrong? So, let's talk about it. So, normal hemostasis has three phases: vasoconstriction, the platelet plug formation, and coagulation cascade. And that turns into a fibrin clot. And in hemophilia, platelets work fine. The initial plug forms and the fibrin scaffold never stabilizes. So the clot becomes weak, fragile, and collapses. So this means that bleeding restarts, the wound oozes, internal bleeding can continue being unseen, and this is why hemophilia causes delayed healing and not just immediate hemorrhage. Why does hemophilia damages the joints and limbs? So repeated bleeding into the joints is called hemoarthrosis, which leads to synovial inflammation, cartilage destruction, chronic pain, deformity, immobility, and immobility then causes muscle atrophy, venous stasis, skin fragility, and secondary wound risk. So, hemophilia is not just a bleeding disorder, it becomes a mobility and wound disorder. What wounds for hemophiliac patients are prone to? Okay. So, hemophilia patients are especially vulnerable to prolonged bleeding from minor cuts, deep muscle hematomas, joint bleeds mimicking infection, retroperineal bleeding. That's something that one of my family members had, unfortunately. Intracranial hemorrhage, post-operative bleeding, wound dehiscence, and delayed healing after debridement. So add diabetes and PDA, peripheral arterial disease, with it, and the risk multiplies. So how do we diagnose hemophilia today? So modern diagnosis is precise. A prolonged APTT, a normal PT slash INR, a normal platelet count, specific factor assays like factor 8 and factor 9 levels, genetic testing when indicated, but this matters because you should never debride blind. So, how would we treat hemophilia today? So, factor replacement therapy, which is recombinant factor 8 or recombinant factor 9, on demand or prophylactic. Newer therapies extend half life factors. And then there's non factor agents like an antibody for hemophilia A. And then acute bleed management. Factor first, then rest, ice, compression, and elevation. And be careful with the compression aspect, okay? And pain control without NSAIDs, okay? Because bleeding disorders are treated before wounds, not after. So when it comes to debridement, okay, in a hemophilia, how not to kill the patient, okay? Here's where clinicians can get in trouble. Rules for debridement. Never debride without factor coverage, okay? Coordinate with hematology. Use conservative techniques. Prefer sharp, precise, minimal trauma. Avoid aggressive curettage. Control bleeding meticulously and monitor post procedure for delayed hemorrhage. This is not optional. This is like survival. Okay. So when it comes to Alexander Romanov, you have to think also when it comes to that, think a little bit about the history of him. Okay. So Alexander Romanov, he was born August 12th, 1904. Okay. He was the only son of the Tsar II and San Cassandra Alexandra, meaning he was like the heir to the Russian Empire. And in royal families, heirs are not just children, they're like the national infrastructure and a living symbol of stability and a political future. Okay. And in history, they had early reports that describe prolonged healing, a classic for inherited bleeding disorder. Okay. And the problem wasn't that he bleed. It was the problem was he didn't clot normally, okay? And, you know, I hope people are aware because everybody knows about the Anastasia thing, right? Alexandre Say and his family was killed July 17th, 1818 during the February Revolution in 1917. They said he was held. They were exiled, moved to multiple locations, and ultimately held. But they said that him and his family, is killed July 17th, 1819. Okay. So I also wanted to talk about Rasputin. Okay. And the miracle question, right? Rasputin influenced surge because the royal family believed that he could ease Alexei pain and sometimes stop the bleeding. Okay. Now, clinicians are Rasputin, but no, hemophilia is not cured by prayers or hypnosis. But here's the clinically interesting part. Multiple historians and commentators suggest a plausible mechanism for why Alexei sometimes improved after Rasputin intervened without evoking magic. Stress reduction. So calming Alexandra reduced chaos around the child and then caused less agitation, better rest, and less re-injury. Okay. Stop stopping harmful med. One hypothesis is that Rasputin discouraged doctors from giving aspirin. I mean, aspirin is like a blood thinner, right? Aspirin then at that time was used for pain before its antiplatelet effect, which was widely understood, which could worsen bleeding. And then also strict rest and reduce manipulations, fewer examinations, fewer movement, and handling of the child with a deep hematoma can reduce the rereading list. Okay. Also, I forgot to mention that hemophilia also has another one. So we talked about hemophilia A, B, right? And then hemophilia C, which is a factor 11 deficiency, okay? But we already talked about how it is acquired, right? Through the X recessive disorder trait. But can you get hemophilia without a family history? Yes. There are two main ways. One way is through a new mutation in the factor gene, which can happen spontaneously. And then there's acquired hemophilia, which is much more rare, but autoantibodies against the factor 8, which is like a different clinical scenario, often in adults or postpartum autoimmune or malignant associated conditions, okay? And so when hemophilia is primary, a secondary hemostasis problem. So there are two pathways when it comes to the clotting cascade. There's intrinsic versus extrinsic, okay? And why it matters, and I know everybody in like medical school, we have to deal with this. So extrinsic pathway, that's the tissue factors, and they tend to affect the PT and INR. The intrinsic factors, which are factors like 7, 11, 9, 8, affect the APTT. So hemophilia A and B are intrinsic pathway disorders, which classically prolong the APTT, but the PT itself is normal. So think of it like building a brick wall, which are the platelets, and then pouring cement, which is the fibrin, okay? Hemophilia patients can lay the bricks, but the cement supply is broken. So the wall collapses after or then later, calling a delayed bleeding, which is signature. So, like we talked about, the bleeding is deep in hemophiliacs. So, and forgive me for calling it hemophiliacs, it's just hemophilia, patients who have hemophilia. But the platelet problem causes like petechiae as well, mucosal bleeding, superficial oozing. And like we talked about earlier, they get hemoarthrosis, which is bleeding in the joints, and deep muscles hematoma, and serious bleeding after trauma or procedures. So, like we said, the wounds there, those are the ones that they're prone to. So, if it becomes a kind of a loop. So, if the patient bleeds and then they have pain and then they deal with immobility and weakness, and then that leads to more instability and more falls, that causes more bleeds. Okay. So, why the external wounds can be a bigger deal. So even the smallest laceration can cause the patient to bleed longer, rebleed after it seems fine, and complicate debridement. So we talked about the screening. So initial workup, you definitely have to get a CBC and platelet. Platelets are usually normal in a classic hemophilia patient. The PT and INR are often normal. It is the APTT that is often prolonged in hemophilia. And mixing studies can help differentiate the factor deficiency versus the inhibitor. So keep that in mind. So, like we said, the PT and the INR are usually normal in hemophilia A and B. And APT is often prolonged, which means it's the intrinsic pathway impairment. Okay? So, what do we do? Oh, so there's anti-fri. What do we do to treat it? We already went a little bit on it, but I forgot to mention that anti-fibrolytics, okay, which is like a tranexamic acid for mucosal bleeding and procedural support, and desmopressin. because I want to say desmogods or whatever, like Stranger Things, but some mild, that's for some mild hemophilia A, okay? So, practical approach when it comes to dealing that. So the rule is plan the bleed before you touch the wound. And we talked a little bit earlier about that. So for meaningful debridement, you need hematology, like we said, don't forget about this, recent factor levels and inhibitory status, factor replacement plan, time to the procedure, and local hemostatic strategy. Okay. So in a hemophilia patient, minor procedures is a dangerous phase and the wound doesn't know your intentions, okay? So keep that in mind. And avoid chasing the bleed with repeated cutting and, stop and reset. For most patients who have hemophilia, debridement is, kind of catastrophic, but they have slow, persistent bleeding, rebleeding at home, rebleeding in the tissue plates, and delayed bleeding hours later. So prevention looks like correct factor coverage and timing, layered hemostasis, low trauma dressing plans, and reliable follow up. Okay. Next, let's say you have a patient who is a hemophiliac and, let's say they have a deep wound, right? A big gas, right? Why should we not use a wound vac on a patient like this? Okay, so keep that in mind. Because even when a patient's on a blood thinner, you have to keep that in mind and you shouldn't use, in my opinion, err on the side of caution, but I would not use wound vac on that patient because you could just pretty much suck out the majority of their blood and make them anemic, right? So, although negative pressure wound device therapy can be life changing for many wounds, right? It's not a casual tool that is used in high risk bleeding patients, okay? So, negative pressure wound therapy complications include bleeding among the common issues. So, you have to flag patients who are at high risk of bleeding, aka patients with clotting disorders, right? So, the mechanism of risk, let's use wound care logic. The suction can disrupt the fragile neovascular tissue. The foam or granulation interface can bleed when changed because it does cause good granulation bleeding tissue. Negative pressure can pull on the small vessels, and if bleeding starts under occlusive dressing, and it can accumulate unnoticed. So, in severe patients with hemophilia, especially without immediate factor support, monitoring, or expertise, negative pressure wound therapy can turn a manageable wound into a hidden hemorrhage. So keep that in mind. So just keep that in mind. Consult hematology first and vascular, but most likely err on the side of caution. I wouldn't use it. But so Alexei Romanov's story isn't just about tragedy; it's a clinical story and I try my best to keep it up with the royal runes. But bleeding disorder can create invisible wounds, joints, muscles, and in compartments. And like I said, hemophilia isn't just bleeding more, it's clotting differently, clotting later, clotting deeper. And procedure planning with a patient with hemophilia isn't just optional, it's procedural, okay? And tools like a wound vac therapy demand respect. And using the wrong tool on the wrong patient at the wrong time can be catastrophic. So I hope everybody enjoyed this today's episode of Royal Wounds because a crown couldn't just protect him from his missing clotted factor, but in modern medicine, done right, we can protect patients now. So we're going to continue with this series of Royal Wounds, and I hope everybody enjoyed this episode of Diabetic Foot Files, Royal Wounds with Hemophilia about Alexei Romanov. And this is Dr. G. Take care of your feet because they take care of you.